Nick Mangerison here. Welcome to Top Med Talk. Now, before we get cracking, Top Med Talk is going to be at the International Fluid Academy Day on November the 23rd in Amsterdam. Full details, topmedtalk.com. Click on the section marked Events. You'll be able to find out more. It's on November the 23rd. It's in Amsterdam. It's the International Fluid Academy Day. Going to tell you more about that towards the end of the podcast. In the meantime, it's time for today's Top Med Talk. Smoking kills more than all addictive substances combined, plus car accidents. This is part 3 of 3. Parts 2 and 1 precede this on your podcatcher. It's presented by James Davis, Director of the Duke Smoking Cessation Programme. And it's about standing up a preoperative smoking cessation programme in your institution. It's the final of 3 parts, like I say. So if you have a look into the back catalogue, you'll find the previous 2 parts, which make this a complete talk. More words about that towards the end. Before that, though, let's have a listen.
Top Med Talk.
Behavioral treatment. The big news on behavioral treatment is the more sessions you do, the better it works. And these are the kind of treatments that are effective: motivational interviewing, contracting, where you say, I'm looking you in the eye, I'm shaking your hand, we're signing a piece of paper, you're going to quit, yes I am, and it's very basic stuff, but here's the day you're going to quit, yes, I'm going to do it. Skills training, what do you do when you have urges? Mindfulness, here's a practice of breathing and being in the present moment during these challenges. Social support, it's bringing partners in. And then follow-up has been interesting. People often do fairly well for a brief period of time, but for a few weeks, but as time goes on, they start to lapse or relapse. And follow-up means being in touch with them, typically over the phone, calling them on the phone. There are IVR systems that have been developed, and there's texting and emails. But this can make a real difference. There's There's an Ottawa model. A lot of folks in Canada are doing this now. And then Nancy Rigotti at Harvard did a great study on this that showed, good increase in outcomes, just following people on the phone. And what that means is when people on the phone say, hey, I lapsed, then you can talk them through it, or lapse means I had a cigarette or two. Or if they say, no, I'm completely back to smoking the way I was, you bring them back in for retreatment. And that's what's really making the difference, is you've got enough contact with people to bring them back, keep them in the system, and bring them back and treat them as needed. So here's our program. This is essentially taking those evidence-based methods that we've just been looking at and saying, how do we implement them? On arrival, they do an evaluation. That's where we're looking at depression, anxiety, alcohol use, all of those things, which may not actually show up in their medical record. I have people who have very high anxiety scores, but they don't have a diagnosis of generalized anxiety, and I can do a GAD, generalized anxiety disorder scale, and get it pretty quickly. I also check carbon monoxide, and we're checking spirometry. The reason we're checking spirometry, at first I thought, well, this is kind of a bit of a waste, but then I found that of those smokers who come in to the center, who come into one of our clinics, who do not have a diagnosis of COPD, about 20% of them actually have undiagnosed COPD. Now, I don't do spirometry on a 20-year-old, but most of the people in our clinic are not 20. They're coming in and they're 40 or 50. And so we're doing spirometry, and then we send them on to pulmonology if they have a new diagnosis of COPD. We're catching a lot of that. Then there's the medical provider visit, and here we have, it's mostly run by PAs and NPs. I run one of the clinics myself, and so I guess there's an MD in it also. But these people all have tobacco treatment specialist training, and it means that they understand, they've learned about more contemporary algorithms of managing patients, more contemporary medication treatment strategies like the ones that I was talking about. Behavioral providers, LCSW, again, with tobacco treatment specialist training, and then we've got phone-based follow-up, and we've got a medical assistant who, again, is TTS trained to provide that. So we're just looking at the evidence of what works and trying to kind of fill in the boxes is what we're doing here. This is kind of about standing up the course. This is a training program. We are a little fortunate because we have the Duke UNC Tobacco Treatment Specialist Training Program, and so we can put all of our providers through our own program for free. That looks at, there's a big list of things that we do there. The manual is now 450 pages, I've been told. 30 different authors. That gives you, that's run through TT, people who are going through the course get a national exam from Etude, and then if they pass that and they've gone through the course successfully, then they get a credential, which is nationally recognized now, which is this, they become a certified tobacco treatment specialist. Recertification is required every 2 years, and this is really becoming, the TTS kind of credential came up, I bet, 10 years ago or so, but it is really becoming kind of nationally recognized, and states are now looking. I just had a conversation with the director for Medicaid reform in North Carolina, who is looking at reimbursing providers when they have this credential for the work that they're doing. And I'm, of course, in favor of that. I think that would be terrific as long as it's done right. Additional training. So we treat people in the cancer center. We are treating people prior to surgery. We're treating people who are in psych. We have a smoking clinic within the HIV center. All of those areas require kind of specialized treatment knowledge. And so we offer that kind of specialized training. Then we've tailored we use Epic, and we've tailored the electronic health record Navigator so that it provides support for the kinds of things that are needed in smoking cessation. We need to do training for billing and documentation and how to conduct referrals for our providers. Then I do mentorship where I just hold their hand and hang out with them for a few days, and then they text me, and I get a few texts every day from a provider going, my patient was on varenicline and passed out. Is that varenicline? Continuing education, we also provide that. So this is... And then the perioperative medicine space is just getting started, but we're going to be operating within Duke Perioperative Medicine. The referrals, essentially we'll have all smokers referred into the perioperative clinic. The workflow will be modified to meet the timing of upcoming surgery, and then smoking cessation meds are often stopped. There's some surgeons that feel we don't typically want nicotine around during surgery because of some vasoconstriction. That can often be stopped. We still need to kind of sort out whether varenicline is okay or bupropion. And many times I think they might be okay, and so we'll need to kind of look at that. And then importantly, patients are seen after the surgery. That's really important. Many patients will quit for surgery, and this is this enormous opportunity because they're so highly motivated. But once the surgery's done, then they're back to smoking again. The data on this is really shabby. I was looking for good studies on people who quit in the perioperative domain, and then kind of what happened downstream, and there's not much information on it. Anecdotally, I can tell you that the majority of them go back to smoking, which is very disappointing. But this is, I think, really critical. What happens after the surgery, and how can we support sustained abstinence? I think there's a lot of work to be done there. In terms of data collection, this is just a rich area. We collect data we do carbon monoxide testing on every patient in every visit. So we have biochemically confirmed abstinence on everyone, demographics, understandings about specific surgeries, different comorbidities, the surgical outcomes themselves, cost outcomes. We actually have a health economist working on our team, and then long-term smoking outcomes, which I was just saying we really need more there. So I have a short case to present. So this is a 68-year-old white male coming into the Duke Smoking Cessation Program, has had hip pain for 2 years. This is being scheduled for non-emergent arthroplasty. The surgery is 8 weeks out. The surgeon has said, this guy's got to quit or I'm not going to take him. And let me know how it goes, which I love. That means patients patient and I and the surgeon are all seeing this the same way. This guy has smoked a pack and a half per day for 52 years. That's 30 cigarettes per day. So that is a 78 pack year history. That's pretty substantial. It's pretty substantial tobacco burden. Carbon monoxide testing is 38. We would a CO would need to be carbon monoxide need to be under 7 in order to be considered abstinent in our group. So this is high. Spirometry testing found this was one of these guys who did not have a diagnosis of COPD, but if his FEV1 or FVC drops below 70, that's COPD, and he's at 72%. So I drew out the little curve for him and said, "Look, you're just about on the line for COPD." The Fagerstrom test for nicotine dependence, which gives us an idea of his kind of physical dependence, came out at 9. So that, the range is 2 to 10. So this guy, just from the evaluation, I go, he's almost has COPD, high CO, and he's right up at the roof in terms of his physical dependence. And he fit that kind of model for being high dependence. He tried to quit over 10 times. He's always unsuccessful. He's tried everything, and he hasn't been able to quit. And on further kind of discussion, his withdrawal symptoms were not managed through the use of medications. And I thought, great, you've found the right place because we treat people like you. So kind of things that I'm thinking about, when does this guy need to quit smoking? I want him to quit 4 weeks. I want him to be quit for at least a month before he goes into surgery. So kind of what actually happened? This was multiple visits. On the initial visit, this was a fellow who, these high dependence people respond particularly well to varenicline and bupropion combinations. Varenicline increases dopamine. One of our hypotheses about this group is that they have big suppressions of dopamine. Varenicline boosts dopamine, and bupropion. Those are our two best dopamine boosters. And so there are studies that demonstrate you really get an impact from using these two. I start them at different times, though. I typically start varenicline, and then a few days later I'll start the bupropion, so that people have some sense if they're getting side effects from one or the other, which it is. And then I asked him, you're smoking 30 cigarettes a day, drop down to 15 and let's see how it goes. If the medications are not working, he's not going to be able to get down to 15, or if he does get down to 15, he'll be feeling horrible. Then I said, come back in a week, because we don't have a lot of time before surgery. We've got to move things. This is the pre-quit visit. Check. He was doing well. He dropped down to, I think he was a little lower than that. I think it was 14, 13. He's doing well. He did not have substantial side effects from the Chantix or the bupropion, and we decided, okay, let's set up the quit day. We set up the quit day for 3 days later. Really kind of talked through. Then this was a very behavioral visit. The first visit was all meds. Then we really talked through the quit day, kind of worked through all the details of that. And now he's quitting essentially 6.5 weeks before surgery. Then I see them in the next week. And this is the post-quit visit. It's 3-4 days after his quit day. Came back with a CO at 4 ppms. Sometimes that's abstinent. Sometimes with COPD, it's not 2 or 1. It tends to be a little bit higher. Decided to continue medications. Then we gave him a phone call right the week before surgery to say, hey, are you still quit? He said, yep, I'm still quit. We didn't bring him in for a retest. We are trusting this one. And then after surgery, we scheduled him for a visit, said, hey, how's it going? That's kind of that other piece. We want to make sure that he's staying quit, that he has the support, that he's doing okay with medications. There were no surprises there. And then we did a 12-week post-quit follow-up. That's when the medications are ending. And sometimes people with severe dependence or people who've been smoking a long time need a longer course. This person did not feel like he needed a longer course, but we did continue the phone-based follow-up over a year, and those are very brief calls. Hey, how's it going? You still quitting? You still quit or not? And then we just keep it in a file. So that's kind of, just to get a sense of kind of how that works. This is kind of a nice case because he came in way in advance. This is a very non-acute situation. Thank you.
This is taken from the hugely successful EBPOM-USA Master's Course, Perioperative Care Practicum, which took place in Atlanta earlier this year. I mentioned at the beginning of the podcast we're going to be covering the International Fluid Academy Day on November the 23rd in Amsterdam. Now, this is a great opportunity for you to meet the team if you want to come along. All you need to do is check out the website, topmedtalk.com, click through to events, and you'll find a full piece on the website detailing everything you need to know about the International Fluid Academy Day, November the 23rd. Now, we've set up a Slido account for people who want to interact with us and our guests during the International Fluid Academy Day. Here's how you get to that. Go to slido.com. I've got a login for you. It's hashtag TMTIFAD18. So IFAD, International Fluid Day 18, and TMT, of course, standing for Top Med Talk. So that password, once again, slido.com, hashtag TMTIFAD18. So TMT IFAD 18 is an easy way of remembering that. You can get onto there, put your question in early, and have a chance of having it answered sooner rather than later. Don't forget that login, TMT IFAD 18. That's hashtag TMT IFAD 18, and that's on slido.com. And then, of course, if you think you can come along to the day itself, that'd be great. We'd love to see you. Amsterdam, November the 23rd. Go to the website, topmedtalk.com, and click on the section marked Events. Also, of course, you can download our full back catalogue at the moment here on Top Med Talk. All you need to do is go to your podcatcher and click Download All, or scroll through them individually and clicking Download on each one, or go to the website, topmedtalk.com, and explore our back catalogue, downloading as many as you can. It's entirely free. You can get all of the back catalogue at the moment. We're currently sorting through it, so it may not always be available in that form. So get yourself to the website, topmedtalk.com, and download all of our podcasts, our entire archive, whole back catalogue, many hundreds of valuable podcasts with incredible information within.